This is chapter 38. We're going to start talking about care of the patients with acute coronary syndromes, things along the lines like unstable angina and myocardial infarctions and things along those lines. So, coronary artery disease. Coronary artery disease is one of the single largest killers of American men and women in all of ethnic groups. Basically, coronary artery disease is a broad terms. It includes chronic stable angina and acute coronary syndromes. It can incorporate a lot of things that just really affect the heart. Coronary artery disease affects the arteries that supply blood, oxygen, and nutrients to the myocardium. Remember, the myocardium is your heart muscles. So as the blood is flowing through your coronary arteries, it can become partially or completely blocked. When this happens, you get ischemia. Remember, all ischemia is just a reduced blood flow through those arteries. Or you can get an infarction. An infarction is necrosis or cell death, and this occurs again when that ischemia is prolonged. You don't have enough perfusion through those areas, and it does cause irreversible damage to the tissues. So we have chronic stable angina pectoris, and please don't get caught up in all of these terms. We're going to keep things real simple. So don't sweat the small stuff here. But with CSA, these patients have a chest discomfort, and it occurs a lot of times with exercise, with prolonged or an extended amount of exercise or exertion. And most of the patients who have a stable angina know they have it. The symptoms can remain the same over several months. These patients don't generally have much of a limitation of activity. They normally can do just about everything. And you see this in patients that generally have what we call a fixed atherosclerotic plaque. That means they've got some plaque buildup in there, and it's just in one spot, and it's fixed to the wall of the vessel. You can see this from patients that have, a small amount of heart disease, patients who eat high fatty foods, overweight people. So just for a number of reasons, the chronic CSA is generally relieved with nitroglycerin or with the patient just resting. And a lot of times physicians can put patients on certain types of drug therapy that helps with the stable angina. It's, again, just a temporary imbalance between the coronary artery's ability to supply oxygen and the cardiac muscle's demand for oxygen. This is limited in duration, and it doesn't cause permanent damage to that heart muscle. So with acute coronary syndrome, this is unstable angina, and all angina means is a chest pain. With ACS, you have an atherosclerotic plaque, that same plaque, but this time it ruptures in that coronary artery. You get a lot of platelet aggregation. Those platelets start to clump, and you get a big clot plus vasoconstriction along with that. The degree of how much obstruction you have determines on how much plaque you have in there. That artery has to have at least 40% plaque buildup before it stops and before it blocks the blood flow. Most of the time with acute coronary syndrome, when you're looking at their EKG, you would see what they call an ST segment elevation in the EKG, but that's not always the case anymore. So they generally start to classify the ACSs in three different types of categories. An ST elevation is a STEMI, and then a non-ST elevation is an N-STEMI. So the STEMI is an STEMI, and a non-STEMI is an N-STEMI. The non-STEMIs are common in women, and then they also have unstable angina pectoris. And we're going to go over just a little bit about these, but like I said, I don't want you to get hung up on the terms. So unstable angina pectoris. Unstable angina is just the most common used term for here. It's just chest pain or discomfort. Again, this occurs at rest or with some amounts of exertion, but this time it causes a lot of limitation for these patients. They may be able to walk from the house to the mailbox one day, and then the next day they can't do that. They have to sit down, take a rest. This continues to increase in the number of attacks and the intensity of how long the chest pain is. The pressure can last longer than 15 minutes. Rest and nitroglycerin probably will not take care of this type of pain. Unstable angina can also describe new onset angina, Prince-Metzels angina, and pre-infarction angina. Patients with unstable angina do have ST changes on their EKG, but they do not have changes in their troponin or CK levels. Troponin levels are pretty specific to the heart muscle and to the probability of a myocardial infarction. Creatinine kinase levels or CK levels are more specific to muscle involvement, not even necessarily heart muscle, but just muscle involvement in general. New onset angina talks about a person who's got their first symptoms, usually after exertion, like with exercise, or they've overdone one day, or any type of activity that puts increased demands on the heart. Prince-Metzels angina is chest pain that results from the coronary artery spasming. It typically occurs after rest. And then the pre-infarction angina is chest pain that occurs in days or weeks prior to that patient actually having that real big heart attack. Again, patients will present with the ST changes, but will not have changes in those lab values. Troponin and CK levels are lab values. So now let's talk about the myocardial infarction. This is the most serious of all of the coronary syndromes. It's often referred to as an acute MI or an AMI. If this is not diagnosed or treated, it can lead to death. It occurs when the myocardial tissue is abruptly and severely deprived of oxygen. This can occur with a myocardial infarction. It can occur with trauma. The blood flow is very quickly reduced by like 80 to 90%. You start having ischemia. That ischemia, because of the decreased blood flow, leads to injury. It leads to necrosis. So now you have cell death. And if this is not restored, then this patient, like I said, can die. These patients will normally have ST elevations on their EKG. The cardiac enzymes that we're talking about can be normal when these patients first come in, but then they'll start to elevate over the next 3 to 12 hours. Causes of a non-STEMI are coronary vasospasms, dissections, and sluggish blood flow due to narrowing of the coronary artery. So you ask, what kind of things can cause a narrowing of that coronary artery? Well, stenosis does. That's when you can have some decreased blood flow there. It's when you have plaque buildup. You may have, and then the blood's having to try to reroute itself around it. So those type of things can cause sluggish blood flow. Also buildup of fatty acids, triglycerides. Those fatty lipids can build up in there. So patients that appear with a STEMI. STEMIs are a pretty severe and medical emergency. Patients with a STEMI have an ST elevation. They also will have an elevation in their blood work. A STEMI is a rupture of that plaque, of that atherosclerotic plaque again, and you have the platelet aggregation, and then you get a big clot at that site where it ruptured. when that ruptures, when that clot ruptures, there is 100% occlusion to that coronary artery. Again, it's a medical emergency and it requires immediate surgical prevention. They have to get this patient to the cath lab. They may have to get some stents in there to open up that blocked artery. Ventricular remodeling is basically when scar tissue permanently changes the size and the shape of the left ventricle. It may decrease the function in that ventricle. It can cause heart failure, and it can increase morbidity and mortality. This tissue doesn't contract. It doesn't conduct electrically like the heart muscle is supposed to. And it can also cause ventricular dysrhythmias. That's irregular arrhythmias in the ventricular muscle. So just remember that it's scar tissue, and it helps to change the size and shape of your left ventricle. So this just shows the myocardial infarction and and this is the in-STEMI and the regular STEMI. Again, remember with your in-STEMI, you have ST elevation, but a lot of the times your lab work may be perfectly normal and will start to rise several hours afterwards. With a STEMI, you are going to have an ST elevation as well, but then your troponin and your CK enzymes are going to be elevated on admission. There's not any single laboratory test to diagnose an MI. You'll generally see a troponin T and troponin 1 RAND. These markers are specific for the MI and for cardiac necrosis. Your CKMBs too are specific more for muscle function, but the CKMB doesn't peak until about 24 hours after the onset of pain, so they may not be elevated when the patient is first admitted. Myoglobin is also looked at. Of course, an imaging assessment, a 12 lead EKG may show elevations in the ST segment, and of course a cardiac catheterization to see where there may be a blockage. As far as the imaging, you can do an echocardiogram to look at the valves of the heart. They can also do a CT angiogram, which can it helps diagnose coronary artery disease. And again, I already mentioned the 12 lead EKG to look at this as well. So how are we going to manage this person's pain? Nitroglycerin, of course. Remember that nitroglycerin helps increase the blood flow to the area. The nitroglycerin also helps to dilate the coronary arteries, making blood flow better, and then also it helps to decrease the oxygen demand by the body. If it is just strictly angina, it usually does respond to the nitroglycerin. The patient will tell you that the pain is relieved or definitely diminished. If you have pain that is not relieved with the nitroglycerin, you can give them morphine. Morphine helps to decrease, again, that oxygen demand. It relaxes smooth muscle and reduces the circulating catecholamines. You want to, of course, monitor for the side effects of morphine, which help to, or respiratory depression, hypotension, and bradycardia. And most of the time with the morphine, this pain will get better. Any patient that comes in severe chest pain or angina, you need to make sure you put oxygen on them. You want to put them in a semi-Fowler's position in a quiet environment and a calm environment to help decrease stimulation. So with a diagnosis of ineffective tissue perfusion, these patients are going to be probably on lifelong thrombolytic agents. Sometimes it may be as simple as an 81 milligram aspirin a day. As you know, the aspirin helps to inhibit the platelet aggregation so the platelets aren't clumping, and then also helps with vasoconstriction, therefore decreasing the lack of a clot. The restoration of perfusion to injured area limits amount of extension, improves left ventricular function. This statement is just basically saying that we need, restoring the blood flow to the injured areas improves the function in the ventricular system, and then completely reperfusing that area within just a couple of hours after an MI has decreased the mortality rate significantly. Looking at thrombolytic therapy, I'm sure most of us have heard of TPA, which is what a lot of physicians will start as soon as the patient gets to the hospital. They generally first give them aspirin or have the family member give them aspirin if the patient is at home. And what fibrolytic therapy does is it does start to dissolve the clot in the coronary arteries, and then therefore restores myocardial blood flow. Three listed down here are your tissue, your TPA, retiflase, and tenecteplase are just different types of basically clot busters. And generally the one you'll see more than others tends to be the TPA. Other drug therapies that can be used with patients who have had an MI are glycoprotein inhibitors. These target the platelet component of the clot. It's administered IV, and it basically prevents the fibrinogen that we have from attaching to your platelets at the site of the thrombus. Beta blockers are also really good for MIs. They decrease the size of the infarct, and they also help to increase the mortality. It's to help decrease mortality rates in patients with MI. Most physicians will go ahead and prescribe this beta blocker within 1 to 2 hours after the MI if the patient is stable. Beta blockers slow the heart rate, and they decrease the force of that contraction. This helps to prolong the period of diastole, so it prolongs the rest period while reducing the force of the contraction. So beta blockers help the heart perform more work without a decrease in the blood flow. But with beta blocker therapy, you want to monitor for bradycardia. You don't want to give if your pulse rate is less than 55 or if your systolic blood pressure is below 100 without checking with the physician. You want to look for hypotension, a decreased level of consciousness, and of course chest comfort. You need to be listening for crackles. That's indicative of heart failure, and wheezes, which is indicative of bronchospasms. They can also be given calcium channel blockers. And calcium channel blockers are used for chronic stable angina when they're not successful in managing the chronic stable angina. They can be added to the drug regimen, and these particular medications also have anti-angina properties in them as well. They're pretty effective in relieving the pain associated with the chronic stable angina. And then Ranexa is a calcium channel blocker. Percutaneous transluminal coronary angioplasty is basically a procedure to help open up the clotted coronary artery and restore the blood flow to the area. The thing with this procedure is they're going to have to be on antithrombolytics for quite a long period of time. They'll get clopidogrel or Plavix prior to the procedure. They'll be on IV heparin for several days after the procedure, the cardiologist can generally restore blood flow within 2 to 3 hours after the onset of symptoms. The patients, you want to monitor the patient for signs and symptoms the clot is being dissolved. Hopefully their chest pain will go away. If they've got an ST elevation, then that should revert back to normal. You'll be doing lab work, looking at your PT and PTT during this time. And then they're going to be on long-term therapy. They're going to be on antiplatelet therapy. They're going to be on beta blockers, possibly ACE inhibitors or ARBs during this time. And this is just a picture of how they actually put the catheter up through the artery and into that vessel. And then it's an uninflated balloon. They inflate the balloon and it flattens out that plaque wall, and then the blood flow is restored. So other procedures that we can look at for restoring flow: an arthrectomy is a device that actually can go up inside the artery and retrieve the plaque, or can emulsify it so that it'll come out easier. Stents is where they'll go in and put a small long device in there, and then the blood flow goes around the occlusion. And then a rheolytic thrombectomy is kind of like a washing procedure where the it uses a low pressure, high speed saline jet, and it helps to break the clot up. This picture just shows a coronary stent. You see that stent's in there, and then the blood flow can go right through the occlusion. So this picture is of a coronary artery bypass graft surgery, also known as a CABG. CABGs are performed, it's the most common type of cardiac surgery and the most common procedure for older adults. Most of them are done for patients older than 65 years of age, and it's where they actually bypass the patient's own blood vessels and will graft to other areas, so that it kind of bypasses and they move the blood flow around. It's indicated when patients don't respond to medical management of a coronary artery disease, or when the patient has disease progression. And this is just another area where it shows, you can tell where they have taken and bypassed here to have a different set of blood flow. So surgical management for MIs, minimally invasive direct coronary artery bypass, which we just discussed, and you don't have to worry about these others listed on here. Just a few things that I didn't mention. Realize that women typically tend to have an atypical type of angina. You don't generally see like the aching jaw pain, the choking sensation. With women, you can see fatigue, sleep disturbance. They may complain of heartburn, dyspnea, and also with the older adult, they don't tend to have the chest pain as well. They can have some shortness of breath. They may be disoriented because of the poor cardiac output. I've even seen patients complain of a cough. So just realize that you have to assess any type of abnormal symptom that you have with these patients, especially if they've had a history of coronary artery disease. Also remember, with nitroglycerin, you need to make sure the patients are not on things like Cialis or Viagra. Home care management. A lot of these patients may need to be under cardiac rehab to help them promote rest, and to know that they can do their ADLs by themselves, and also to work into getting back to exercise. We want these patients to be independent again and use all the resources that they have out there for them. You don't have to worry about page 770 to 80, but start back. Make sure you read page 780, 81, and 82 because it does go over some of the home care. And make sure you're looking at all of your green boxes because I just lay your signs and symptoms and your nursing care out there. Thank you. This is the end of this chapter.